Hello and welcome to the third seminar of Public Health 1, which is called Epidemiologic Methodology. This seminar aims to give you an overview of the science and practice of epidemiology and the different designs of studies that are used by epidemiologists to understand and investigate diseases in human societies. So let's see the definition of epidemiology at the beginning. It's the study that aims to understand distribution and determinants of health-related states or events in specified populations and the application of this study to the control of health problems. So it simply means that epidemiologists are always working to find out the reasons for disease in human societies. So you can also imagine that this is the only science, epidemiology, that sees diseases as social phenomena rather than individual events, because all other clinical subjects that you will learn in the next coming years are focused on the pathophysiology of the disease and how disease alters the human body function or the anatomy of the human body. But at the end of the day, this is not enough to understand why disease happen or how we can react in order to treat these diseases or even prevent them. So epidemiology tries to see the common factors between the people who are sick in order to determine what can be the risk factors for this disease. And the word itself comes from Latin language, and it means epi, which is upon or above, or demos, which are the people, and finally logos, which is a study. So the first epidemiologist we have seen in history is Hippocrates, who is also accredited to be the father of medicine, if you remember from the first seminar, because Hippocrates tried to find out what are the reasons of illness. And unlike all previous attempts of finding out the answer for this question, Hippocrates was thinking that the environment where humans live could have an effect on the human body that could lead to the disease. That's why this idea inspired the following philosophers, researchers, scientists, physicians in the upcoming centuries until we realize that diseases are caused by different risk factors as we understand today. But the first human that thought that environment could have an effect on the human body that could lead to the disease was Hippocrates. Yet his theory was not that robust as you understand, because this was like hundreds of years back, but he was accredited to be the first human to propose this idea. And also the word epidemiology itself came from Hippocrates and his textbook. Then we have John Snow. And John Snow was a British physician living in the middle of the 19th century, between 1813 to 1858. At his time, there was a huge outbreak of cholera in London, and just for your reference, cholera was outbreaking in every like 5 or 4 years in Europe and probably all over the world as well. At this time, this was a very common illness. That's why at his time in mid of the 1850s, he was really thinking why the disease is taking place that massively and rapidly among the individuals in London. And so his effort led to the conclusion that the cholera was not an airborne infection, as most people thought at this time, but it was a waterborne infection. And the method that he used to verify this idea or this conclusion was the basis that we use till today to understand diseases. So John Snow is accredited to be the father of modern epidemiology, and the story of John Snow and how he came up with these conclusions that cholera was a waterborne infection is attached to the IS or the interactive syllabi of the scores, so you can watch it later on if you would like, or if you are curious to know what John Snow did actually to come to this conclusion and how his contribution is seen till today as the basis or the birth moment of epidemiology or the modern science of epidemiology. So this was just a quick history overview of epidemiology, and now let's see the different branches or disciplines in epidemiology. As you can see, it's massive in this map, and in this course we will focus primarily on clinical epidemiology and its sub-branches like infectious disease epidemiology, chronic disease epidemiology, and others. But of course we will not aim to qualify you as epidemiologists by the end of this course, or even by the end of your 6 years here in Masaryk, but this is just for you to imagine how the science and practice of epidemiology is diverse, and it includes various disciplines that could touch every aspect of our life. Then let's see how epidemiologists regardless of their specialty or their background, function. So there is a universal approach for epidemiological work. First, epidemiologists need to count the cases or the health events. So they need to be able, or they need to have a method that will enable them to find the cases and count them. Then they need to divide these cases, or the number of these cases, by a meaningful denominator. This can be like time or place or population group, whatever other potential denominators that can be used to divide the total number of cases. And finally, they need to compare these different rates or different ratios over time or among different groups in order to come up with meaningful conclusions. So this is, as I say, the universal approach of epidemiological work, and it can be applied on any situation for any disease or any case, because as I say, this is a universal approach. Then we have the case definition, and this is a very important concept, because if you remember, we say that the first step of the universal epidemiological approach is to count the cases. But before you are able to count something, you need to know what are the characteristics of what you're going to count. For example, if I tell you, please tell me how many apples are there in the market, first you need to have a clear idea about how apples look like, because if you have no reference like this, you'll not be able to count the cases. So the very first step of epidemiological investigation is to give a clear definition for the clinical case or for the case that we are interested in finding. So case definition is, as you can imagine, is a set of standard criteria for classifying whether a human or a person has a particular disease or not. So this is more or less a checklist of some criteria. If this criteria were like satisfied or fulfilled satisfactorily, then in this case we can say that this human is suffering from this disease or not. All right, so the case definitions generally are designed and also updated on regular basis at a national level in order to facilitate comparability. So the case definition of diabetes mellitus in Czech Republic or in the European Union in general is more or less the same, because this will facilitate later on the comparison of rates of the same disease in different municipalities or different states within the like place where this national case definition was used. And finally, these case definitions need to be equivalent as much as possible between larger places in order to facilitate, as I said earlier, counting of cases and their comparability. So let's see what are the basic components of the case definition. The components of case definition can be also dependent on the objective and the context when this case definition will be used. And I will give you very soon some examples for why this is the case, like why case definitions can change from place to place according to the objective of the case definition. But in general, case definition components are clinical criteria in addition to parameters of time, place, and person. Okay, so there is a set of clinical criteria that are confirmatory laboratory tests that are commonly used, but of course not all diseases have confirmatory laboratory indicators. But if not, then at least there should be subjective symptoms and objective signs. And just for your information from now on, subjective symptoms are the manifestations or the clinical manifestations that patients or humans perceive. Okay, so if someone come to tell you in the future, oh, I had terrible headache last night, this is a clinical symptom, because this clinical symptom or this manifestation was only experienced by the patient, but you as a doctor or you as a physician, you can never see it. Okay, however, the objective sign is the manifestation or the clinical manifestations that you can see by your eye or using some diagnostic tool. For example, if you see the skin of your patient is reddened or reddish, in this case, this is an objective sign because you have seen it, right? Fever is also an objective sign because you can measure it using the thermometer, okay? So subjective symptom is something that the patients will only feel and report. However, objective sign is the things that physicians or doctors can see and measure. Okay, so both of them are definitely usable for clinical criteria for the case definition. And finally, here's the question that I would like you to investigate more or search more for its answer, which is how case definition for chronic disease surveillance could be different from case definition for investigation of infectious disease outbreak. Just in a nutshell, to answer this question, case definitions for chronic disease surveillance are not updated that rapidly in comparison to the case definition of infectious disease outbreaks. Okay, so the frequency of updating the case definition of chronic diseases is probably slower. Also, the case definition of infectious diseases could have more parameters regarding to the outbreak or the epicenter of the outbreak, like the place of the outbreak, the time or the interval where this outbreak started, and also the type of humans who could be possibly affected by this outbreak. In chronic diseases surveillance, this is not possible because we know that cancers or other chronic diseases will never have these outbreaks or like epicenters. That's why we can never have parameters for time, place, or person for chronic diseases. Of course, there are many parameters that can be used for this comparison, and I recommend you to start search for it because this is part of your self-study. Okay, so let's see examples for case definitions. This is listeriosis, and this is an example of a bacterial infection, and this is the case definition for listeriosis during surveillance time, or during, I would say, peaceful time. There was no outbreak at this time, so that's why the criteria that you see here are purely clinical and laboratory criteria. There is no information about the place or the time or the person that could be possibly affected. That's why this is a case definition for surveillance purpose. However, there is another case definition for the same disease, which is listeriosis. This is the same bacterial infection that we mentioned earlier. And here there was an outbreak during the year 2000 until the beginning of 2001 in North Carolina. And as you can see, the criteria had changed slightly. So we have more parameters related to the place, the time, and potentially also the person who are the inhabitants of this region or the residents of this region. So this is an example of the case definition for outbreak investigation. All right, see here we have Kawasaki disease or Kawasaki syndrome case definition, and this is an example of one of the rare diseases that affect pediatric patients or children under the age of 5 years. Now, like this is a little bit different, but still Kawasaki is a rare syndrome, and in all cases, either now or earlier when the screenshot was taken, we have no biological or laboratory indicator for this disease. So the clinical diagnosis of this disease is based on the American Heart Association criteria. There are 5 criteria that need to be fulfilled, at least if the child shown 3 out of these 5 criteria, we should suspect Kawasaki syndrome. So this is, for example, bilateral conjunctival infection or oral changes or peripheral extremity changes or rash or cervical lymphadenopathy. So all these symptoms, if 3 of them at least were found out in the child, then you should think of the Kawasaki diagnosis, because you can never ask for any laboratory test to confirm this. Another example here is from measles outbreak in 1996, and what you can see here is what we call the case classification or the case stratification. So stratification of cases or classification of cases means that we will stratify our certainty of the case based on how much information we know about its infection. So for example, the suspected case is any febrile illness accompanied by rash. So this is probably like very uncertain or like very primitive level of certainty. But then we have the probable case, which is more certain, and the confirmed case, which is way more certain because we have also laboratory confirmation for the diagnosis. Why we make this stratification? Because for each group of patients we can have different measures. For example, for the confirmed cases we can start straightforward the medical treatments. For the probable cases we can keep them under investigation to see the changes, and then we can start the treatments immediately. And for suspected cases we can just isolate them or keep them away from others because we don't want the infection to spread into society. And then we are also aiming to control the outbreak in this way. So this case classification is always important for infectious disease outbreak investigation because it can control the outbreak itself and also help the individuals who are affected by the infection. Okay, so now we will move to the second part of this seminar, which is about the different study designs in epidemiology. This classification is really basic because I know that in case that you are interested in learning more about epidemiology, you may find more sub-study designs or subcategories for the study designs, but I will not be able to accommodate all of them for you in this course as you are still in first year. But later on, if you are interested, I can recommend you individually or personally other references to learn more about the subdivisions of these study designs. But let's focus now on these basic types. Okay, so the first dichotomy we see here in this categorization is the comparison between observational study designs and experimental study designs. So what is the difference between them? Why we call some studies as purely observational and other studies as experimental studies? Observational studies are the studies that are only watching the disease and how they grow in the community without any way or any intention to change how this disease is spreading in the society. So we will not do any intervention to change how humans are behaving or how humans are even treated in hospitals in order to see the effect of these changes. We will just let everyone live in their daily lives and do whatever they would like to do as they would like to do, and then we will keep recording this. So if you just keep an eye on how humans are living or how humans are treated, this is observational study because you didn't do any change for their normal life. However, in experimental study designs, you're doing an intervention in order to see the effect of this intervention on human lives and their health outcomes. So if you make a clinical trial, for example, as you can see here in this example, in order to see the effect of a certain medicine, you will be able to see the effect of this medicine when you compare the two groups, those who receive the medicine and those who did not receive the medicine. And based on this comparison, you can decide which was the case, like whether this medicine was effective or not. So in this study design, I mean in this clinical trial, we made a change for how these humans are living or how these humans are treated. And that's why it's called interventional study or experimental study. Then within the observational study group, you have another dichotomy, which is descriptive studies versus analytical studies. And the difference between descriptive studies and analytical studies is that descriptive studies only describe the disease without any intention to find out what are the potential reasons or the potential risk factors for this disease. So we do not do any categories or any subgroups or any comparison between the people who have the disease, because this is not the purpose of descriptive studies. The purpose of descriptive studies is to describe how the disease look like, how the patients who have this disease look like, how the communities of this disease, how they are affected, just to describe how they are, without any intention to understand what could be possibly behind this disease or what could be possibly behind what we see. But if you are interested to understand what is behind this disease or what is behind this problem in your society, then you need to do some sophisticated work, which is analytical work. And this analysis or these analytical study designs aim to understand what are the reasons for disease or what are the reasons for mortality. That's why we have cross-sectional studies, case control, and cohort studies, as you will understand later on, that are all examples for analytical study designs because they aim to understand what are the reasons for disease. Okay? And now let's jump to the very first type of epidemiologic studies, which are called surveillance studies. In surveillance studies, epidemiologists do not do any effort to collect data from population or from the field because they are relying or they use the data that had been already collected routinely in the society. For example, you can see here the maternal mortality rates. So maternal mortality rates are routinely collected by the central government in order to keep it for like other purposes, not only for health sector, but for other sectors of the state administration. And for the purpose of surveillance study, you can make these rates on a graphical platform like this, and you can read it and you can make some suggestions or conclusions based on this. But of course, your suggestions or your conclusion at this stage will be very primitive because you do not know for sure why these people suffered from this disease or why those people died in larger number than what was expected at this time. So for example, when you look at this figure, you can see that starting from 1975 until 1975, there was a gradual decline in the rates of mortality in Sweden, which means that there was a successive or continuous improvement in health outcomes for the mothers in Sweden. But at the same time, you can see that in certain periods of the history, there was spikes, there was some increase. And for example, here between 1850 until 1875, there was an increase. And if you don't know what are the possible reasons for this, there is a suggestion that there could be an economic recession at this time that led to deterioration of living conditions of Swedish people, and that's why this could be an explanation for the increase of mortality rates at this time. Of course, this explanation, as I said, is a primitive explanation because we didn't know much information about the characteristics of the mothers who died at this time. Maybe they were not part of the low socioeconomic groups or the groups that were affected by this economic recession. Maybe they died because of totally different reasons. But reading these graphs will start to help you thinking of the potential reasons for the problems. Okay, so you're not giving a solution yet, you're not giving an answer yet for why this is the case, but when you look at this data, you may think of some reasons, and later on you need to do different effort or more effort in order to understand if your hypothesis or if your suggestions were valid or not. Okay, the most common example for surveillance studies is called the global burden of disease, and in the second lecture we talked about it in detail, so I refer you to watch the second lecture PowerPoint in order to understand more about the global burden of disease. In general, global burden of disease, this is the most common example for surveillance studies because they are based on mortality data and morbidity data from different countries in the world, and this is, as I say, the best example for surveillance studies. Then we have the second type, which is ecological studies, and ecological studies are not also different from surveillance studies in a way that both of them do not collect data from individual humans or individual patients. They are based on data that had been already collected by the government in order to keep track on changes in the society. And the different name or the other name of ecological study is correlational studies. So they can be also called correlational studies in some references or in some textbook. And these studies are also useful, like surveillance studies, for generating hypotheses. So remember that surveillance studies and ecological studies are very primitive study designs that cannot give an answer. However, they can give hypotheses, and hypotheses are a form of scientific questions. They can just give suggestion for what can be the reason for this, but they can never give you a confirmation or an answer for these suggestions. They are easy to conduct, the same for surveillance studies, because you don't do any effort to collect this data. This data had been already collected for different purposes, but you have to be careful because these data, which were collected for different purposes, they may not serve perfectly for your purpose of your investigation. So here, when you look at this graph, this is the death during heat wave in Paris in the year 2003. You can see that there is some sort of correlation between the daily temperature, which is represented by the connected lines, either the maximum temperature or the minimum temperature. And at the same time, you can see in the histograms or in these bars, the number of mortality or the number of deaths every day. And you may think that there was some correlation between the high temperature of the weather at this time and the increased number of deaths or the increased number of mortality. Yes, there is some sort of correlation, and you may think that heat wave was the reason for this increased mortality, but this suggestion or this idea can never be validated slowly or exclusively based on these data. You need to do further investigation to confirm this idea. For example, there could be a lot of other reasons for the increased mortality. Maybe during heat wave or during this time, the people who died in these excessive numbers were not even outside the homes. Maybe they died indoors. Maybe they died in hospitals, right? So there is a number of possibilities that could explain this increased mortality rather than the increased temperature. Yes, increased temperature could have an effect, as we know, but this is not probably the only reason. And that's why ecological studies are not enough to give answers. They may help you to generate hypotheses or to give suggestions that can later on help you to make studies or focused research to investigate these hypotheses. But based on ecological studies, you can never get an answer. And you have to be careful because some epidemiologists and even medical scientists make this huge mistake, which is called ecological fallacy, which is also called sometimes spurious correlations. So spurious correlations or ecological fallacies can be seen in this graph, for example. When you look at this graph, there are two lines. One line, which is the red line, represents the US spending on science, space, and technology over the years from 1999 until the year 2009. And at the same period, the black line represents the rates of suicides by hanging or strangulation or suffocation. So as you can see, there is a perfect correlation, right? But can you think of any meaningful or useful explanation for this correlation? I'm afraid that there is nothing like this. So in this case, this correlation cannot give you an answer for the increased rates of suicide. The same also for the rate of people who drowned or like die by falling into pools, and the amount of movies that Nicolas Cage appear in every year. So yes, there is some correlation as you can see, but I'm afraid that Nicolas Cage can be a reason for this because of course like people can die from seeing Nicolas Cage, but I don't think this is like the case. This is just a joke. Of course, this correlation as well cannot give you any explanation or any meaningful result. Also, the per capita consumption of mozzarella cheese and the rates of civil engineering doctorates or PhDs awarded, the divorce rate in Maine, and the consumption of margarine. So all these correlations are perfect when we think about mathematics or statistics. However, in real life, they can never give you any useful information. That's why you have to be careful, because correlation does not imply causation. Having two things happening at the same time does not mean that these two things are connected or one of them is the reason for the other one. Okay, so this was the ecological studies. Then we have the third type of descriptive observational studies, which is called case report or case series. Case report and case series are pretty similar in a way that both of them are detailed clinical report on the signs, symptoms, diagnosis, treatment, and follow-up outcomes of either individual patients or several similar cases. The most common successful example for case report came from the 1981. In 1981, there was a paper published in the Morbidity and Mortality Weekly Report, which is the official journal of the American CDC, or Centers for Disease Control and Prevention. This paper or this article titled like as what you see here, it's pneumocystis pneumonia in Los Angeles. In this case report, there was a group of 5 young men who were all active homosexuals, and they were treated for biopsy-confirmed pneumocystis carni pneumonia at 3 different hospitals. The interesting information about those group is that none of them were suffering from a disease that could suggest these infection, because we know that this infection can only happen for only, for example, cancer patients or very old patients who suffer from other chronic illnesses, especially kidney disease and others. So those people have usually reduced immunity, and because of this reduced immunity, we can expect those individuals to have pneumonia or pneumocystis carni pneumonia. However, those young humans were healthy. None of them have any problems that could suggest that they have good pneumonia. All right. Then, in the same journal, after a few weeks, there was another paper coming from New York for a case report for other 26 homosexual men that were suffering from similar symptoms for the symptoms that were described above. And from this moment, the investigations started not only in the US and Europe and high-income countries, but it was probably all over the world as well. And after 2 years, we realized that all these cases that nobody had an explanation for why they happen, they are all attributed to a retrovirus called HIV, or the human immunodeficiency virus. And this is the reason for AIDS, if you would like to know. So this is the way how we discovered AIDS or HIV. And the interesting part about this story is that it was a single case report that started all these worldwide investigations that led to the discovery of the illness. The same also happened with COVID-19 in the late of 2019, when a group of cases was reported to the WHO office in China, in Wuhan, describing strange cases of pneumonia. Nobody knew what were the reason behind it, but then we realized that these are all connected to a coronavirus disease, which is COVID-19. Okay, so case report and case series can be different in not only in the number of cases, because case report can also include more than one case. So if you have one human, if you have one single case, this is strictly a case report. It can never be called a case series. But if you have a group of cases, this still can be a case report or case series. And you will see here what's the difference between case report or case series for a group of patients. So if the group of patients are described individually, which means that you have case 1 who is 30-year-old asymptomatic, asthmatic, non-smoking, physically active, hypertensive female, and then you have a detailed information or detailed explanation for the second case, which is 45-year-old diabetic, sedentary, hypertensive, non-smoking male. Then case 3 is 52-year-old postmenopausal, osteoporotic, non-drinking, physically inactive female. So if you have this detailed information about each and every case in your group, then this is called case report. And here you have a screenshot for an example for how case reports appear in medical journals. So if you have this detailed history of each case, then in this case, this group is described as case report. But if you have no specific information or no detailed history for each patient, and then you have only one table, like these tables that you see, that describes the symptoms of all the cases in the group collectively in just one place without the detailed history or the detailed story of each case, in this case, this is called a case series. So one more time, just to summarize this, case report is always for one human. Sorry, if you have one human, this is always called case report. But if you have a group of individuals that are detailed or explained in detail, this is called case report. But if you have this group without much detailed information about each individual in the group, in this case, we will call it a case series. Okay. Then these are just examples for our work during COVID-19, when we had described a number of case series and case reports for individuals who were suffering from COVID-19, was interesting and unexpected as well oral manifestations that could, as we thought at this time, help in early diagnosis of the disease. And based on our work that we were doing during the year 2020 and the beginning of 2021, there were also other groups working on the same issue from different countries in the world. There was finally systematic reviews and meta-analysis for these cases worldwide, and our work was cited there. And yeah, we helped the scientific community to learn about the symptoms that could possibly diagnosed in COVID patients at the early stages. Okay, so let's see the other types of study designs that we use in epidemiology, and it's cross-sectional studies. Cross-sectional studies is the first example of analytical observational studies, because they can understand or they can give an explanation for the reason of illness. So the other terminologies that was used earlier for cross-sectional studies is prevalence studies, because if you would like, for example, to know the prevalence of smoking among first-year medical students, you will go to make a questionnaire and distribute it among all students, and in this survey you will know how many students said yes for the smoking question and how many students said no. And making this measurement, you will learn the prevalence of the problem in your society or in your population. Okay, so cross-sectional studies are done in very short period of time, and that's why they are very useful to learn the prevalence of the diseases. That's why they were earlier called prevalence studies. Be careful, because the estimation or the measurement for the exposure, which is the potential reason for illness, and the effect, which is the illness itself or the result of this exposure or this risk factor, are made at the same time. Okay, and very soon I will explain you how this is problematic, because you will never learn who came first. Is it the exposure came before the effect, or the effect came before the exposure? Because you measure them at the same moment. There was no time for follow-up or to see what happened in the timeline or the history of the patient. The quality of cross-sectional studies is totally dependent on how much these cross-sectional studies using representative samples. So the more representative the samples that you collected from your general population, the higher the quality of your evidence from cross-sectional studies. The best cross-sectional studies that are done on a national basis are routinely updated and uploaded to this database, which is called GHO, or the Global Health Observatory, which is part of the WHO databases. In this database, you can see an update for every 2 years on the tobacco consumption rates or tobacco use prevalence in different countries. Okay, so this is the cross-sectional studies. And in order to make you imagine cross-sectional studies in, I would say, more realistic way, imagine that you are sitting at your home or in your home at 10 p.m. and then you are bored because it's almost the end of the day, and you're thinking to watch a movie on Netflix. You know that all movies that are delivered or streamed on Netflix are on average 120 minutes. And you have this burden to think of which movie you're gonna watch, because you have no time probably to watch 120 minutes from each movie and then decide, okay, this is the one that I would like to watch. You are still confused and you have no idea which movie you're gonna watch. So you need to have some method or some tool to help you choose between these movies like as early as possible in order to make a decision and then watch your movie. So there are always trailers that are short summary for these movies that can be usually like 1 to 2 minutes, that describe what can be the story or what can be the possible story of this movie without too much spoilers, of course. But then from these 2 minutes or these short like video, you can decide whether this movie is interesting for you or not. So this is exactly the relationship between the cross-sectional studies and real life. Cross-sectional studies are designed and they are measured in a very short period of time. That's why they are more or less the trailer of the interactions between humans and their environment. And they are also the interaction between risk factors and diseases. So they cannot tell you the exact details of these interactions because they are very short or they are done in a very short period of time. However, they can give you an idea about what could possibly happen in the real world. For example, when you look at the trailer, you will see different scenes from the movie from different points that can help you to give this like general idea about the long movie. For example, here when you see the poster of Harry Potter, you can make an assumption or a quick assumption that this movie is more or less about magicians or some fairy tales at this time. Also, when you look at the poster of Titanic, you can imagine that this is probably about the story of the famous ship Titanic, and there was probably also some romantic story about it as well within this movie. So having a look on the trailer or the poster of the movie will help you to have an idea about the 2-hour movie itself. And the same, this also what we can get from cross-sectional studies about the real world interactions. So there are 2 different types of cross-sectional studies, and this again, before we jump to the 2 types of cross-sectional studies, the interaction between the real world and cross-sectional studies. So the real world have a very lengthy process for smokers to turn into lung cancer patients. This is usually 20 years, and not all smokers, of course, will turn to be lung cancer patients, maybe few of them. But let's say that you did a cross-sectional survey among people who are smoking and people who are not smoking. So this is just a random survey, and you found out that out of the 25 lung cancer patients in your study, there were 20 smokers. So in this case, this is 80%, and this is a huge number, of course. If you compare it to the non-smokers, this is probably like great risk for having lung cancer. That's why you need to be careful, because the cross-sectional study will not be able to tell you specifically what happened before what. For example, you don't know whether these lung cancer patients started to smoke before they have the disease or not. Yes, we know that they are smokers, 20 of them are smokers, but you don't know whether they started to smoke before having the disease or maybe after having the disease. That's why, again, cross-sectional studies are limited in the type and the amount of information that it can give us. Okay, so the two types of cross-sectional studies, as you can see here, are called descriptive versus analytical studies. So let's focus on the first part, which is descriptive studies. Descriptive cross-sectional studies are called descriptive because they are only interested in the prevalence of the problem. So if you would like to know the prevalence of diabetes mellitus type 2 in Brno, you need to count all cases of diabetes mellitus type 2 maybe this year, and this would be 30,000 cases, and then you have to divide this number by the total population of the city, which is 300,000. So in this case, you can say that the prevalence of the problem is 10%, and this is purely descriptive, because learning this information, you will never be able to understand what are the reasons for these 10%. Is it because of some behavioral risk factors or genetic risk factors or other biological risk factors? You have no idea. You just know the distribution or the prevalence of the problem without much information about the potential risk factors. However, if you did more investigation in this survey, or if you asked for more questions in this survey regarding, for example, sex or age group, like in this second table, or sorry, in this second part, in the table of this second part, you will be able probably to give some conclusions or some suggestions for what are the potential risk factors for this problem. For example, you have found out that among the population of the city, there were 150,000 females and another 150,000 males. And the number of cases among females was 10,000, and among males this was 20,000. So if you would like to measure the prevalence in female and in male cohorts, you will find out that in males this is 2 times. This is 13.3% compared to 6.7% of females. So in this case, you can fairly say that males are at greater risk of getting diabetes mellitus type 2 than females. And by the way, this is true, but it's not so like that huge. It's not 2 times more than females, but males are usually at high risk of diabetes type 2. For age groups as well, you can see that middle age group has a higher risk of having a disease or higher prevalence of having a disease compared to young individuals, and old age group is the highest group. So in this case, you can say age is also a potential factor or potential reason for the illness, but of course this is not the only reason. There are many other reasons, and having this information, having this detailed information about the populations that have the problem will help you to understand what can be the reasons for this. So getting only information about the prevalence will make the study as descriptive, but having more information about the people who have the disease, like their sex, their age groups, their BMI, their other potential risk factors, this will lead to the conclusion about the potential risk factors, and this is called analytical cross-sectional studies. All right, so let's see examples for cross-sectional studies that we did in the last couple of years on COVID-19 vaccines. For example, this study aimed to find out the prevalence and risk factors of COVID-19 vaccine side effects. And in this graph, for example, you can see that females had higher incidence of side effects. Okay, you know this information because we compared the prevalence of the side effects among each subgroup of the population, and this is called analytical cross-sectional study for this purpose, or because of this reason. Then we have another study that aimed to understand the attitudes of students and Czech universities toward vaccination. And we can say that students who study medicine or healthcare related sciences, those had the highest level of acceptance compared to all other students. Then on the other hand, we had students who studied agriculture, for example, had the lowest level of acceptance and probably one of the highest level of hesitancy. The students who studied military sciences had the highest level of hesitancy, And yeah, based on this graph, you have specific information about the high risk groups, or the groups that have higher levels of resistance or hesitancy, and then you can decide, okay, this group needs more focused interventions or more promotional interventions to improve their knowledge and attitudes toward vaccination. Again, both examples here are analytical cross-sectional studies. Then we have cohort studies, and cohort studies are studies that are also trying to find out the reasons for illness, but in a more, I would say, expensive style. So why it's expensive? Because you need to spend time in following and recording the patients that, or the people who could be later turned to be patients. And that's why they are called follow-up studies or incidence studies. Usually they take long periods of time because diseases does not emerge in 1 or 2 days. They take years, and that's why you need to keep an eye on the individuals who are volunteering to join your studies during this period. The most common example that we use to explain cohort studies, and by the way, this is study that I will explain here is a real study. This happened in the 1950s in the UK, and it's still running. This study was a cohort study that aimed to understand the effect of smoking on cardiovascular health. And let's see that we had healthy population. Everyone was healthy at this time. Nobody had cardiovascular disease. Yes, there could be people who had cardiovascular disease, but we will not look at them when we start our study. We will focus only on the healthy population. Within this healthy population, we can find that there are two subgroups. One group who are exposed to smoking or exposed to the risk factor, which is smoking, and the other group who is not exposed to smoking, who are the non-smokers. So red color represent the smokers, the black color represent the non-smokers. So these are the people who are living in the society, and all of them are healthy. None of them have cardiovascular disease. And then we will select randomly some of those who are smokers, I mean those who are exposed to the risk factor, which is smoking, and we will also randomly collect another group of the healthy individuals who are also non-smokers or non-exposed. So now we have a group of exposed individuals and another group of non-exposed individuals. And then we will keep follow both groups for 20 years. After 20 years, you will see that among the exposed individuals or among the smokers, there were a subgroup of cardiovascular disease patients or people who got cardiovascular disease, and there are other smokers who did not get any cardiovascular disease, which is great. But of course, there are some who got the disease. As well, the same will happen for the non-exposed group. Some of them will have the disease and others will not have the disease. And the question here, why the non-smokers could have cardiovascular disease? The answer is very simple, because cardiovascular disease is a multifactorial disease, which means that it's not only smoking that could lead to the disease, but there are many other diseases. Okay, so here we have a discrimination between exposed versus non-exposed, and then a follow-up for 20 years to see the outcomes of each group, and then we will record the number of smokers as number of healthy people in each cohort, the exposed cohort and the non-exposed cohort, and then we will compare these numbers. Of course, the numbers will tell you that among the exposed or among the smokers, the percentage of cardiovascular disease patients was way higher than the percentage of cardiovascular disease patients in the non-smoker group, and that's why we started to believe that smoking is a risk factor for cardiovascular disease. So as you can see here, this is called a cohort study or a follow-up study, because we started from a healthy population that were subgrouped into exposed versus non-exposed. Both of them are still healthy at the beginning, but then within 20 years, those people will turn to be sick or they will remain healthy, and based on comparing the numbers of those who were sick or healthy in both exposed and versus non-exposed cohorts, we can learn if the exposure or the smoking in this case was a reason for this increased number of cases. Okay, the cohort studies have also two subtypes or subdivisions. Imagine that we are living today in the year 2023. Okay, and there was a hospital in the year 2000. It was an oncologic hospital. It's a hospital that is specialized in treating cancer patients. Okay, and at this time in the year 2000, there were some cancer patients who were suggested to have either chemotherapy or radiotherapy. The suggestion here, or the indication of having chemotherapy or radiotherapy, was made based on the recommendation from the physician. we as researchers did not influence this decision from the physicians or the clinicians. The doctors or the physicians decided to give some patients chemotherapy or radiotherapy totally freely without any influence from our side. And then within the following years, the hospital records indicated that some of those chemotherapy patients and radiotherapy patients got a recurrent cancer or got recurrence for the cancer, and others remained survived, or they didn't have any problem in the following years. And you have to keep in mind that this data came from hospitals, and that's why when you look at the database of the hospital and you do this investigation retrospectively, we call this study as a retrospective or as a historical cohort study. Why it's a retrospective cohort study or why it's a historical cohort study? Because the groups of patients were made in the previous time. This discrimination between chemotherapy group or radiotherapy group happened 20 years back. We did not influence it today, or we didn't start it from today. Okay, but we are lucky because the data or the outcome of these patients are constantly recorded and documented in the hospital database, because this is probably the only hospital in the regions that deals with these patients, and so we can see the rates of recurrence every year and see if these rates are increasing or decreasing. Maybe at the beginning it was high and then it declined gradually. So seeing these changes over years and what happened for the chemotherapy versus the radiotherapy patients is called a retrospective historical cohort study. Okay, then the other classic design of cohort studies is called prospective cohort studies. But how we do prospective cohort studies? Imagine that we have two groups of smokers and non-smokers today at the year 2023. So at the moment we will start the study, okay, and we had discriminated these two groups based on their exposure, which is smoking, and we know that both of them are still healthy, and we will keep follow these two groups for the next 30 years until the year 2050. And within the 30 years, we may find out that some people got lung cancer and others survived in both the smoking and the non-smoking group. So this work will be done in the future or in a prospective way. That's why you will look at the data prospectively, and you collect the data mainly from surveys. So every year you will give survey for the smoker and non-smoker volunteers and ask them about their healthy behaviors, their health outcomes, their other interesting information, and based on this you will prospectively see the outcomes of the exposure in the future. That's why it's called prospective cohort study. Now you have seen the two types of cohort studies, the retrospective versus the prospective cohort studies. Retrospective studies had been already done in the past, and we get the information only from medical databases. We cannot do it anyway outside of databases. But in prospective cohort studies, we do the study in the future. That's why we have the luxury to do whatever examinations or whatever investigations we do, we would like to do, like for example, self-reported information like questionnaires or surveys, or maybe laboratory tests or other clinical tests to get this information. Okay, so this is a quick summary for the common characteristics that are potentially used in cohort studies and their purposes. I will let you read it as part of your self-study as well. And now let's see the case control studies. Case control studies are, on the other hand, compared to cohort studies, are easier and they don't take much time like cohort studies, because we try to focus on the causes of illness. However, this is more useful for rare diseases. So imagine that you are looking for a disease that only happen in 5 children out of each 1 million. So it means that in order to make a cohort study for this disease, you need to collect 2 million children, and you're gonna follow them for I don't know how many years in order to see only one group of them, which is the exposed group, having 5 cases. So this is extremely expensive and economically non-justified or inefficient. That's why case control studies came to resolve this problem for rare diseases. Also, they can be used for other purposes, not only to serve the investigation of rare diseases, but as I said, rare diseases is the most common and the best example for why case control studies are a good alternative for cohort studies. They are also cheaper and take less time. That's why they are more practical for some investigations. So let's see how we do case control studies. First, we will look at the people who have the disease or the problem at the moment. So this is called the case group. So case group, will be, for example, the cases of cardiovascular disease. So you will collect 100 cardiovascular patients who are suffering from this disease at the moment, or maybe this time. And then we will collect another group of healthy individuals, which we call the control group. So the control group, or this blue group, which are the healthy volunteers, will be more or less similar to the cardiovascular disease patients. It means that they could have the same age, or the same sex, or the same gender, or the same socioeconomic status, the same level of education. So they will be similar in each and every aspect except the disease, because one group will have the problem with the disease and the other group will not have this problem. And then we will ask each of them about their previous exposures. So we will see how many of the cardiovascular disease patients today used to be smoker in the previous time. So you will find out that some of them were exposed to smoking and others were not exposed, like some of them were smokers and another group was not a smoker. The same also will be asked for healthy individuals. We will see how many of them used to be smokers and how many of them used to be non-smokers. So making this investigation at the moment and seeing what happened earlier in time or in the previous years, this is called case control study. Okay, be careful, because the data that we collect about the previous time or about history is not recorded anywhere. We only get it from questionnaires or from surveys. So we only ask the patients and we rely on their self-reported outcomes. That's why this cannot be considered as retrospective cohort study, because retrospective cohort studies are more reliable because we get the data from medical records or medical databases that are way more trustworthy and way more reliable than patient information. Okay, or self-reported information from patients. Okay, the question here is that how we select controls, how we will find out these perfect 100 healthy individuals who are similar to our patients in each and every aspect. There are several methods for how to select controls. The first method is called population approach, and here it's very simple. You will have 100 cardiovascular disease patients, and at the same time you will go to the general population. You will make announcement maybe in the TV or in the radio or in the newspapers asking for characteristics of the maybe social characteristics or socioeconomic characteristics of the volunteers that you would like to have, and then you will collect a healthy subgroup from the general population very easily. So you will just make an announcement and ask for volunteers who have no problem, who have no cardiovascular problem, of course, and who are middle age, maybe they have good education or high school degree at least, and based on this you will have the healthy subgroup based from or based on the announcement that you did for the general population. But then there is another approach called the cohort approach, and cohort approach is called the cohort approach because it's based on the infrastructure of a cohort study. So imagine that you have an ongoing cohort study that started in the year 2000, and this study is designed to take place until 2040. So now we are in 2023, we are probably in the middle of this study, and anyway, the information about the volunteer groups of smokers and non-smokers is already recorded in databases of the institute that runs this study. Okay, so after some years, or maybe after 20 years, where we are standing today in 2023, there are already groups who had the disease and others who are still fine or still surviving well. Okay, so we will come at this moment and we will collect the cardiovascular disease patients from both the smoker and the non-smoker groups, and this will be the cardiovascular disease patients. I'm sorry for this mistake. CVD is cardiovascular disease. Okay, these cardiovascular disease patients, all right, and we get this information today in 2023, and at the same time we will have an eye on the people who are still fine or have no problem, and we will collect random subgroup of them, which will be the healthy or survived individuals, and then we will compare between them in terms of other risk factors. So maybe you will ask the cardiovascular disease patients about their eating habits or about their family history or about any other potential risk factors, and you will ask the same questions for the healthy individuals, and you will make some assumptions based on this. So again, this selection of the control individuals or the healthy individuals had been made from the information or from the data that the institute, let's say this is the Public Health Institute of your country or your state, which is running this long cohort study. They have the patients' numbers, the patients' emails, their information. So you will not do any effort to find the patients. They are already saved in the database. So you can just call them and make your investigation for the case control study, and that's it. So this is easy way for making case control studies, and it's called nested case control study. Very soon I will explain it in more detail. Then we have another approach for finding controls, which are called the hospital or community controls. So imagine that you have a group of cardiovascular disease patients from, let's say, Bern Hospital or Bohnice Hospital, and in the same hospital there are other non-cardiovascular disease patients. Like there are patients hospitalized in other departments or are treated in other departments. So collecting the information from the patients from other departments from the same hospital and compare them to the cardiovascular disease patients, this is another method for finding out or discovering controls. But be careful, because this approach, which is called the hospital and community controls approach, will control for some systematic biases for the differences between patients and non-patients, because they will be all treated by the same physicians or by the same level of care. But you have to be careful, because these are not really healthy individuals, which means that they could be possibly suffering from other risk factors that could lead to other diseases, and that's why you will not be able to see the difference between the sick individuals and the healthy individuals ideally. Okay, then we have two approaches which are somehow similar to each other, in a way that the sick individual will not be compared to only one healthy individual. So if you remember in the previous three styles, each one volunteer who are healthy is compared to one sick human. Okay, but in the next two styles of finding controls or approaches for finding controls, the one sick individual will be compared to maybe 3 or 4 healthy volunteers. Okay, in the first approach, which is called multiple control groups, we have a group of cardiovascular disease patients. Remember that these were 100 patients. The mean age or the average age of this group was 48.5 years. The female to male ratio was 1.5, which means that there were more females in this group than males. The mean body mass index was 31.8, which means that they were probably more obese than being normal weight, and 60 of them were smokers. So this is the general characteristics of the group of cardiovascular disease patients, the 100 cardiovascular disease patients. And your task now is to find out a group of controls or healthy individuals whose characteristics in general will be similar to the characteristics of this group. So you will have a control group 1, which have a mean age of 48, which is somehow similar to 48.5. Their female to male ratio is 1.6, which is not so different from the patients group. Then the mean BMI is 32.1, and smoking prevalence is 50%. So as you can see, the control group 1, or the control group that we have here for 100 patients, is similar to the for the cardiovascular disease patients group. Okay, and the general characteristics. Then you can try to find out another control group, maybe from another hospital or from another city or from another country, and these are the characteristics of this group, which is more or less similar to the cardiovascular disease patients group. Then you may find another group. So all these groups will have similar characteristics as groups, not as individuals. Maybe the individuals in each group will not be very similar, because this is not the aim of this approach. The aim of this approach is to find similar groups for the group of patients. Okay, so you may have 3 groups, 4 groups, maybe 10 groups of healthy individuals, and the general characteristics of each of these groups should be similar to the general characteristic of the patients group. Then we have the more robust and the more reliable method here, which is called the multiple controls per case. And in this approach, we have more than one healthy individual, or more than one healthy volunteer that is similar to the case. So let's say that we have a list of 5 cases. The first case is 48-year-old female with a 32 BMI and a smoker. Then the second case is 50-year-old male, BMI 33 and non-smoker. And then you can read the rest of the characteristics of the rest of the patients. Then your task is to find out a volunteer who is 48-year-old female, BMI 32 and non-smoker, and this lady shouldn't be suffering from the cardiovascular disease. And then you may find also another volunteer who have the same characteristics, 40-year-old female, BMI 32 and smoker, because these two volunteers that you see here are both of them healthy, but they don't have the disease, so they are very similar to the cardiovascular disease patient number 1, but they don't have the disease. So making this way of recruitment is called multiple controls per case, because you will look at the characteristic of each individual in your cases list, and then you will go to the community and find out maybe 3 or 4 healthy individuals who have the same exact characteristic for each of your patients. Okay, so here the comparisons is made on an individual level rather than a group level like in the previous approach. The multiple control groups approach, or the first approach you see here in this slide, is based on the general characteristics of the patient's group. However, the multiple controls per case is an approach that is based on the characteristics of individual patients in the patient's group. Okay, then this is a quick comparison between cohort studies versus case control studies. I will leave it also for you for self-study. But now I will see how we can merge cohort studies and case control studies. How can we combine them? Because as you can see, cohort studies are more useful because they can give you more precise information about the disease and when it started and all other information that you could be interested to see in the timeline of illness. However, the case control studies are better in a way that they are cheaper and they can be used for multiple diseases and multiple risk factors at the same time. So in this case, we need to find a method that can minimize the disadvantages of each design and increase the advantages by combining them. So the first approach is called nested case control. If you remember, we said that one of the approaches for finding controls for case control studies is called the cohort approach, and this is exactly what you're gonna see here. So we have a normal cohort study. We start with smokers versus non-smokers. Both of them are healthy. None of them have the disease. And then we will keep following them probably for 20 years. And after 20 years, we found out that among the smokers, there was a group of cardiovascular disease patients, and also among the non-smokers, there was a small group of cardiovascular disease patients. And also among smokers and non-smokers, there was anyway people who will stay fine or without cardiovascular disease. So you're gonna collect all the cardiovascular disease patients from the two subgroups that you see here, and this will be the cardiovascular disease patients group for the case control study. And then you will look at the survived cases and you will make a subgroup of them, because this can be maybe like hundreds of thousands of them who are still healthy, and you will only need maybe 100 to be in the same size of the cardiovascular disease patients group, and then you can compare them. So this is called the nested case control study, because after you collect the cardiovascular disease patients and the healthy survived individuals group, which is the control group, you can ask them about other risk factors. As I said earlier, you can ask them about their family history, about their eating habits, about their BMI, and other environmental exposures to see what can be the possible reasons for cardiovascular disease among the patients here. Okay, so this is the first approach. The second approach that you see here is called the case cohort approach. And why it's called the case cohort approach? Because it's more or less similar to the previous approach in a way that we will start with a cohort study that will run for 20 years, and after 20 years we will collect all the patients from the disease from either a smoker cohort or non-smoker cohort, and this will be called the case group, right? So this is the same like the previous method. However, the difference here is in the comparison group, because the comparison group is a sub-cohort. So for example, you have 10,000 smokers that we started with, and at the beginning of the study, we will go to the database and check the information about these 10,000 volunteers who are smokers, and then we will randomly select 1,000 of them, which we will call the sub-cohort of smokers. And this 1,000, when we will follow them up for the next 20 years, like like everyone in the study, we will find out that some of them will have the disease eventually, and many of them will remain healthy. But we will keep this information, or we will keep the information of these 10,000 individuals who are in the subcohort in order to act as a comparison group for the cases group that will have cardiovascular disease. Maybe we are interested to see other risk factors, so we will ask the cardiovascular disease patients group about their previous exposures, not necessarily smoking, but definitely other risk factors, and we will give the same questions for the subcohort to see what happened to them in the previous years. Okay, the case cohort design is probably more interesting and more useful than the nested case control, because it can allow you to look for various diseases, not only the cardiovascular disease, but maybe also other diseases and other risk factors at the same time, because the information about the subcohort is already assigned or is already made at the very beginning of the study without any intention to make bias by looking at the outcome of the patients that will happen in the following years. Okay, so this is the two study designs that can be made on merging, or by merging, sorry, the cohort studies and the case control studies. This is another graph for describing the case cohort studies. As you can see, in the subcohort group, there are mainly healthy people, but there was very few who are sick or had the disease, but it doesn't matter because we will compare all the subcohort to the cases group who are really sick by the end of the study, and then we can make decisions about what we found later on. Okay, now we will go to the the third part of this seminar, which are the interventional studies or experimental study designs. Here we will start with RCTs, or randomized controlled trials. Randomized controlled trials are important in medicine because they can give us precise information about effectiveness of treatments or medicines or even surgeries. So we start with a group of people who are sick and receiving certain treatment, and then another group of people who are sick but not receiving the same treatment. Okay, so here you have patients of diabetes. The first group is called the treatment group because they receive the treatment that we try to evaluate its effectiveness. And then the other group, who is called the control group, will not receive this treatment. Maybe they will receive no treatment at all, or they will receive a placebo treatment, or they will receive conventional treatment, but anyway, they will not receive the new treatment that we try to evaluate. Then after some months or after some weeks, we found out that among the treatment group, there was only one patient who died. However, in the control group, or in the group that did not receive the same treatment, 3 patients died. So it pretty much means that the treatment is useful because it can reduce the mortality in the patients. Okay, be careful, because the method that we use to assign the patients in either treatment group or control group is called random assignment. That's why these studies are called randomized studies or randomized trials, because randomization here serves very well to keep the treatment and the control groups as equal or as similar as possible, in order to make sure that whatever difference or whatever different outcomes that we will see later on should be attributed mainly to the different treatments, not the patient's characteristics. Okay, so here you have a summary for the value of randomization, because as I said, we do randomization because we want to ensure that the difference that we will see in the clinical outcomes of the patients will be mainly attributed to the treatment alone, not to the other characteristics of the patients. And randomization tries to make the treatment and the control groups as much similar as possible for each other. In a well-designed randomized control trial, randomization is based on a predetermined set of measures that I will explain in the very next slides, that aims to make the participants or the patients and also the doctors that are responsible for treating the patients unaware of which treatment that they are receiving or that they are giving. Allocation concealment is the method that we use to make blinding of the patients, and I will very soon explain it in the next slide. So let's see the methods that we use to do randomization. The first method is called systematic allocation, and systematic allocation is based on the idea of making alteration for patients' recruitment. So let's say that all the patients that will come on Saturday, they will receive treatment A, or they will receive the active treatment, and all the patients who will come on Sunday, they will receive the treatment B, or the second treatment, or the placebo treatment. Okay, then the patients who will come on Monday will receive again the treatment A. On Tuesday, they will receive the treatment B, and vice versa. So if you will keep doing this alteration for the treatment on the calendar days, you are making a systematic allocation. Why? Because you are trying to ensure that the chance of having treatment A or treatment B is much random as possible, because you have no influence on the treatment of the patient. This will be designed, or sorry, this will be decided based on which days you will come. Or maybe you will make an allocation in this style. Like, for example, patient number one, that the patient will come at the beginning, or the first patient that will come to the hospital will receive treatment A. The second patient will receive treatment B. Then the third patient will receive treatment A. The fourth patient will receive treatment B, and vice versa. So it means that the odd number patients, or the patients that hold odd numbers in the sequence, will receive treatment A, and all the patients who hold even number in the sequence of patients will receive treatment B. Okay, this can be also another method for systematic allocation. And as you can see, systematic allocation tries to make as much as possible of fair chance for all patients to receive the treatments randomly without any influence from the researchers or the doctors. Okay, so imagine that all Monday patients will receive treatment A, and all Tuesday patients will receive treatment B, or the second treatment. All patients on Thursday will receive treatment A. All patients on Friday receive treatment 2. Okay, so this is how we do systematic allocation. Then another way is called simple randomization, and simple randomization means that you will make this sequence for the patient, not based on when they come to the hospital, but based on IDs that you will give to the computer. So the computer will make this assignment for you, because once you enter the data for the computer, I mean, where you work in the hospital, and the computer has database is connected to the database of the clinical trial, it will tell you, okay, this patient will have an ID of 22, and in case that it's 22, it means that it's an even number. That's why it should take the treatment A. Then you enter the data of another patient, and then the computer will tell you, okay, this patient should have an ID of 59, and that's why this patient should be given the treatment B, because it's an odd number. Then you will, after this, you will give the information about the patient that comes next, and this patient will get the ID number 2 based on what the computer will tell you, and that's why it will receive treatment A, because it's an even number. And you can read the rest of the number of patients in this graph that describes the simple randomization. Again, simple randomization can be done only by computer softwares, because these computer softwares that are connected to the systems of clinical trials can make this allocation randomly, and we can ensure that this allocation is done randomly without any influence or without any bias from researcher's side. Then we have the block randomization, and in block randomization you can imagine something like this. So the first 4 patients will be considered as block 1. The second 4 patients, the patients from number 5 to number 8, will be considered as the second block. The patients from 9 to 12 will be the third block, and the patients from 13 to 16 will be the fourth block. So as you can see, each block of patients here is considered to be one group. Okay, each 4 patients is considered to be one block or one group. And the difference here is that the allocation of treatment in each block should be unique from the other blocks. So the first block is, for example, is given A, B, B. So the first and the second patient given A, and the third and the fourth patient given B, or the second treatment. In the block number 2, we have A, B, because the first patient and the third patient of this block would be given the treatment A, and the third and the second and the fourth patient of the second block will be given treatment B. And then you can understand the rest of the allocation of the cases from this graph. As you can see, like it's the third block is AABB, BBAA. The fourth block is BAAB, and yeah, this allocation will always help you to ensure randomization as much as possible. However, it's not that easy for some clinical trials. That's why We have other approaches for randomization, like for example, the stratified randomization, which is a two-step process that starts with a stratification for the patients based on potential characteristics that can be sources of bias, for example, age, or gender, or other factors. In this case, we need to ensure that the patients who are in treatment A group are similar to the patients in treatment B. For example, as I said, the amount of old people in treatment A should be similar to the amount or the percentage of the old people in treatment B. The same for sex, like the prevalence of females in the first group or the treatment A should be similar to the percentage or the prevalence of females in the treatment B. That's why we do, first of all, stratification. We learn the information about the participants from the database, and so we classify them as females versus males, for example. And then we will make blocks within each group. Like within females, we will have blocks like 4-unit block for females and 4-unit blocks for males, and then we will stratify the treatments within each of these blocks. So by this we are ensuring randomization as much as possible within the patients groups. Then we have the last method of randomization, which is called minimization. And in fact, minimization is not randomization method. It's a method that we use in order to reduce the amount of errors that could come from previous methods of randomization. So for example, if you did simple randomization, or maybe if you did systematic allocation. So systematic allocation will tell you to have all patients who come on Monday in treatment A, and all patients who come on Tuesday in treatment B, and all patients who come on Thursday in treatment A, and all patients who come on Friday in treatment B. But what if for the 1 month of the recruitment you have seen no patients coming on Friday and very little patients come on Tuesday? This pretty much means that the group of treatment B will have no patients, or probably very few number of patients compared to the treatment A. And that's why when we come toward the last maybe 2 weeks of the study, let's say the study will be like run for 1 month for recruitment, and after 2 weeks, which are the first period of this stage, we will look at the characteristics and we will see if there is any potential imbalance going on to happen between the two groups of treatments, and then we can interfere and decide that all next patients will direct it to this other group in order to ensure some balance between the two treatment groups. Okay, so minimization is not really randomization method. However, it's a method that can help to reduce biases or problems that could be taking place based on the methods of randomization. Another concept in randomized controlled trials is called blinding. And blinding is also important as randomization. Both of them are important concepts because blinding will reduce the amount of bias that could happen from the patients or the doctors or even the analysts at the end. So any clinical trial will have 3 components: patients, doctors, and analysts. If you did not tell the patient which treatment that they are given, which could be somehow potentially problematic in terms of ethical concerns, but at the end of the day, this method can be accepted for some medicines and some operations. So in this case, you are blinding the patient, and that's why it's called a single-blinded randomized control trial. Another scenario for making a single-blinded randomized control trial is to not tell the doctor about which treatment that they are giving for the patient. So they will prescribe it, and then there will be a nurse or another member of the team who will be responsible of delivering the injection or delivering the medicine to the patient. So by this, the doctor does not know for sure which treatment the patient is given. But of course, there will be a control team from the clinical trial who will be responsible for ensuring these medicines are given in the proper way and in the proper method. Okay, so this is another technique for making a single-blinded randomized control trial. Either you blind information from the patient or you blind information from the doctor. The double-blinded controlled trials are the trials when the patient and the doctor have no idea about which treatment that they are given. So the medicine, let's say it's a capsule or tablet, and this capsule or tablet will be very similar to the capsule or tablet that is given as placebo. So the same color, the same taste maybe, and also the same smell will be in the placebo pill or the placebo tablet or the placebo capsule, because we want to ensure that the doctor and the patient will not recognize it. Okay, only the clinical trial control team will be able to know and will be will have access to the content of the bill, but the doctors and the patients will have no information like this, in order to ensure that they will not behave differently when they learn this information. And finally, the triple-blinded randomized control trials is when the analyst or the data analyst is at the end also will not know from which group this information or this data are coming, and they are only evaluating the data or they are assessing the data without information whether this data belong to patients who received the treatment or the patients who did not receive the treatment or receive the placebo. Okay, so advantages of randomization and disadvantages of randomization are part of your self-study. I almost covered most of them while we are speaking now, but this again is part of your self-study. And then let's see another example of interventional study. We have field trials, and field trials are examples of interventional studies because we are giving individuals who are healthy an intervention or a medicine or a vaccine that will protect them from being sick in the future. So this is more or less a randomized controlled trial, but it's only made for healthy people, not patients. And that's why the preventive interventions that will be given for some people will be compared or will be seen for the next few weeks, and see if those people who receive the preventive intervention will have the disease or not, and the same also for the people who will not receive this intervention or the control group, whether they will be sick or not. So the comparison here will be made in the same way like we did for the randomized control trials. However, the main difference between field trials and randomized control trials is that field trials have healthy people, randomized control trials have sick humans or sick patients. Field trials have preventive intervention or preventive measure. Randomized control trials usually have therapeutic measure or medicines or drugs. Okay, then we have community trials, and in community trials we are also running an interventional study on a group of people, but these groups are blocked as communities. So we are not looking within the community for individuals who would like to take the vaccine. We will give the vaccine for all the children in this city or in this village, and we will compare them to the other villages who did not receive yet the vaccine and compare the mortality rates for the children or the cases of measles or other disease for the children within this village and other villages. Okay, by this intervention, you are trying to see whether these interventions that you give or these preventive measures that you give for the community will be useful for the community outcomes or not. This is more done not for vaccines, just to be more realistic. It's more given for environmental intervention like access to clean water or cleaner air. So all these interventions that will change the society or the environment are very good examples for community trials. Again, community trials, field trials, both of them are done on healthy people, not on patients. Okay, so let's see the last problem we have for today's seminar, which is confounding. And confounding is the variable that is usually associated with exposure and also associated with the disease. So it's associated with the risk factor and it's also associated with the outcome, which is the disease. However, this is not a part of the causal chain from the exposure to the disease. So this is not one of the consequences of the exposure that will lead to the disease eventually. Let's see this example. We have a cohort study that is done to see the effect of caffeine or coffee drinking on heart disease. So in this cohort study, we have two groups of individuals. Some of them are drinking coffee regularly, and the other group do not drink coffee at all. Okay, and then we keep following those groups for 10 years until we see what are the number of people who have cardiovascular disease or heart disease in both cohorts, the coffee drinking cohort and the non-coffee drinking cohort. Okay, so till now this is a classic cohort study, as you can imagine. But be careful, because during these 10 years, there could be some effect for tobacco, because the people who drink coffee can also be tobacco smokers, and that's why the tobacco smoking itself can cause the disease. And we will not be sure at the end if the disease happened among coffee drinkers, if this disease is associated with coffee drinking or not, or maybe it's caused by smoking, right? So again, tobacco use or tobacco smoking is a confounding variable that will lead to distortion of information that we will learn from this cohort study, because we will not be sure if the disease happened mainly due to coffee drinking or not coffee drinking, or maybe because of smoking or not because of smoking. So what we need to do here is to think about the confounding variables and to find solutions for them. So there are several techniques to control confounding variables that are existing in cohort studies or case control studies or even intervention studies. The first techniques to control confounding variables can be done during the study design. So at the early stage of the study, I mean during the time when you still design the study, before you collect any data or before you examine any patient, from the very beginning when you design your study, you can decide that you randomize the confounding variable among the coffee drinking group and the non-coffee drinking group. So whenever you know that this person is a tobacco smoker, you will randomly allocate them to either the coffee drinking or the non-coffee drinking group randomly without knowing to which groups they will belong. Okay, so this is the randomization method. You have probably learned a lot of information about the techniques that we use for randomization from clinical trials, and these are pretty much similar to what we do for controlling confounding as well. Okay, so this is the first technique to control confounding, by randomizing the confounding variable among the exposed versus the non-exposed groups. Then we have restriction, and in restriction we will have a more radical approach to control confounding. And how we will do this? By telling the people who are smoking that they are not welcomed to join the study. So we will ensure that the group of coffee drinking, the cohort of coffee drinking, and the other cohort of non-coffee drinkers, none of them will be smokers. So at the end of the study, we will make sure that the heart disease or the cardiovascular disease that we will see in this study will be not affected by smoking, or it will not be affected by tobacco smoking, and it will be more or less slowly attributed to coffee drinking. Okay, so restriction is to remove the confounding variable from your study from the very beginning by preventing the people who are engaged with these risk factors, or sorry, with these confounding risk factors, to be part of your study. Be careful, because restriction seems to be a radical solution and very easy because you will prevent them from being in your study, but this is not very helpful at the end, because at the end of your work you need to generalize this data or this information on your general population, and in the general population you will find out very commonly people who are drinking coffee and also smoking tobacco at the same time, and you need to know which behavior or which risk factor is more dangerous in order to control, and which risk factor you need to prioritize resources to control in the society. Okay, so that's why restriction will not help you to generalize your information at the end, because your results will not be applicable for the general population who can be possibly engaged with both risk factors at the same time. Okay, finally we have matching, and matching is another technique that can be decided about from the very beginning of the study, because you can decide, okay, in the first group, in the coffee drinking group, I need to have 10% of the participants as smokers, and in the non-coffee drinking group, or in the second cohort, I need to have 10% of smokers. So by this you are trying to match between the two groups, the exposed cohort group or the exposed cohort and the non-exposed cohort, in terms of the percentage or the amount of the confounding variable. So the confounding variable will be equally represented in both the coffee drinking and non-coffee drinking cohorts. Okay, this is matching. But then if you miss the opportunity to do these techniques at the beginning, or if you don't have a chance to do randomization or restriction or even matching, in this case you need to think about the data that you will get from your patients or from your people at the end. So during analysis phase, or at the last stage of your clinical trial or your cohort study, when you have the data collected and you start to analyze them, you may apply some techniques. The first technique is called stratification. And before I explain you how we do stratification, let's think about this example. We have hospital A, where out of 1,200 surgeries, there were 48 patients died, and you have another hospital, which is Hospital B. In Hospital B, there were 2,400 surgeries happened in the same year. However, 64 of them died. So when you compare the data of Hospital A and Hospital B, you will find out that the overall mortality rate in Hospital A is 4%. However, in Hospital B, it's 2.7%. So if you look at these two numbers, 4% versus 2.7%, you would say, oh, that's awesome. Then next time when I need to have surgery, I will go to Hospital B because the outcome of patients from Hospital B is better than Hospital A. But this may not be very accurate. Why it's not accurate? Because you don't know the characteristics of the patients and the risk of surgeries that were performed in both hospitals. Maybe the patients who visited Hospital B were less sick than the patients who visited Hospital A. Maybe the surgeries that were conducted in Hospital A were more dangerous or were more risky than the surgeries that were conducted in Hospital B. That's why Hospital A has an overall mortality rate like 4% compared to Hospital B. And this is actually the case. When you look at this table, you will find out that the patients were stratified according to the level of preoperative risk, and this is the risk that we have to determine before we do the operation or the surgery. So at the very beginning, we had high risk surgeries, which were 500 patients in Hospital A. 30 of them died, which is 6%, and which is a mortality for high-risk surgeries in Hospital A. And in Hospital B, we had 424 of them died, and so the rate or the risk of mortality in Hospital B for high-risk surgeries were 6%. And the same also for medium risk surgeries. It was 4% on Hospital A and it was 4% on Hospital B. The same for low risk surgeries, it was 0.67 and 0.67 in both hospitals. So when you look at the percentage or the risk of mortality in each subgroup here, which is high risk surgeries, medium risk surgeries, and low risk surgeries, you will find out that both hospitals have equal value or equal number. However, when you look at the total number of deaths divided by the total number of patients in both hospitals, the number will be different because this is the crude value or the crude number. Okay, so you have to be careful and make stratification based on the risk factor, and when you do this stratification you will be able to see whether this confounding variable, which is the preoperative risk, had an effect on the outcome. Then we have the second technique, which is called the standardization or adjustment. And a standardization or adjustment is the mathematical method that we use after doing stratification. So after learning that in each subgroup, the number or the percentage of people who die is similar between the two hospitals, then you will calculate the adjusted value. And I explained it already in the lecture, the second lecture, but if you would like, I can explain it in the classroom because this will be easier for you to understand if you would like. And if not, you can at least read it in your textbook or in your study materials as a self-study to learn what is the standardization or what is adjustment. Again, standardization or adjustment is based on the results that we will get from stratification. Finally, we have statistical modeling, which is similar to standardization or adjustment. However, statistical modeling is done when you have not only one confounding variable, but maybe 5 or more than 5 confounding variables. So if you have a number of confounding variables, in this case, you will not be able to do stratification or even a standardization. You have to do statistical modeling, like regression analysis, for example. Okay. Finally, we have effect modifiers or effect modification. And effect modification is a group or as a subgroup of confounding variables that will always increase the effect of medicines, that will always increase the effect of exposures, that will always lead to overestimation. This is also part of your self-study, and if you reach this point, I would like to thank you for your time and your patience. And I'm looking forward to see all of you this week in the classroom. Thank you.